So it's a shame we can't obviously take questions, but the slides will be available to you, as Professor Bolton has already said, and we can always pass questions through if the contact details aren't on there. So our next talk is from Professor Ketan Dhatariya, who also unfortunately can't be with us. Now, Ketan is well known to many of you. He is a consultant at the Norfolk and Norwich University Hospital and also an honorary professor at the University of East Anglia. He has an extensive CV, but in particular he chairs the Joint British Society's Inpatient Care Group, and he's going to tell us about a pragmatic approach to diabetic foot infections in the UK.
Hello everybody, I'm Ketan Dhatariya and I'm a diabetes doctor from Norwich, and it's a real pleasure for me to have been asked to give this talk at Malvern. I'm really sorry that I can't be with you today and for the meeting, and I'm very grateful to the organisers for allowing me to do my talk virtually. So let me go ahead. This was, let's go backwards, sorry. This is the title of my talk. This was the subject that I've been asked to talk about, and for those of you who've been to Malvern before, you'll know that this is the subject that I've been given before, but a slightly different title, and hopefully I've made it slightly different for those of you who remember what I said a few years ago. So I'm going to start with a quote from the great Mike Edmonds, and congratulations again, Mike, for 40 years at the King's Diabetes Foot Clinic. Certainly that's where I learned my trade initially when I was a registrar. But as you say, he says here that the microbiology of the diabetic foot is unique, and that is absolutely correct. And as my talk goes on, you'll realise that one of your best friends in the foot clinic should be the microbiologist, because they should really be helping you determine what you're doing, both for the individual in front of you and what you should be doing in practice, trying to create your own foot formulary. But I want to go back even further. This again is a paper that Mike wrote in a BMJ with Nicholas Papanas many years ago now, and I would encourage you to go away and look at this. It really is a tiny little piece in that BMJ edition. And really what I want you to focus on is item 4. And it says here, "Thou shalt look carefully for early signs of infection in me and treat me aggressively." And I don't think that anybody could really fault any of these, although I have to say I might update a few of them, given that this is now almost 16 years old, to try and with the technology that we have and things that we could do potentially. When we think about the infection of the foot, there are so many different things to consider, and I won't take you through this slide in too much detail, but as you can see here, there are many, many different factors, as we all know, including the microvascular disease, the angiopathy, leading to the deformity, leading to edema, leading to the abnormal sweating, leading to the inability to feel anything, and wounds, the fact that high glucose doesn't allow the white cells, the infection-fighting cells to work. It's this whole constellation of problems that happen within the foot that lead to it, of course, being the thing that we care so passionately about. And we're trying to deal with all of these, but as we do in the clinic, and we treat people holistically, but I'm going to really focus on looking at what antibiotics we could use and when we need to use them, and what we can do to try and determine whether a wound has actually got an infection or not. I do appreciate this is a busy slide. I'm going to just focus on one little thing here. And as you can see here, this is the list of hospitalization risk for people with infections, comparing people in 2007 with 2016, looking at people with and without diabetes. And I'm not going to, it doesn't specifically talk about the diabetic foot, but it talks about a variety of different infections. And if you can see here, it shows that people with diabetes have been twice as likely to be admitted, almost twice as likely to be admitted for any particular infection when compared to people who don't have diabetes. And that's across the board. And that's been consistent over the last 10 to 15 years. And these are data that was published last year, looking at the admission rates for foot infections. And if you see, what I would like you just to notice is that the vertical scale on both of these panels is a logarithmic scale. So it's not relative, it's a logarithmic scale. So you can see in the red line what are the admission rates of foot infections and osteomyelitis, and those people without diabetes in the red line, and those with diabetes in the blue line. And you can see consistently over the last 20 years or more, the rates of infections and admissions for infections has been much greater in those people with diabetes, as we would mention. So as we'd expect. But when you think about treating the foot and infections in the foot, there are a large number of things that we need to consider. And I've just listed a few on this slide here, which I won't really go into. But you have to think about, and we know about the International Infectious Diseases Society for America guidance from 2012 and subsequently targeted versus empirical antibiotics. How long do you wait to get a swab result or a deep tissue result? What are the most common organisms in your clinic? And that's why you have to have the microbiologist as your best friend. Stewardship, I'll talk about, antibiotic allergies, and so on. But there are these many different things. And my last thing I said on that previous slide was sampling. And of course, many of you may have been involved in this study. Certainly we in Norwich were involved, looking at the differences in superficial wound swabs and versus deep tissue samples, and whether that actually changed what happened to that individual. And what we could find, what these authors found, were that if you took a deep tissue sample, it was much more likely to be associated with growing a wound that was causing infection rather than just colonization. Again, potentially as you might expect. So deep tissue samples are ideally what we want to be taking. We also have a large number of initiatives and directives from a large number of organizations. This is from the World Health Organization. We've got the UK Public Health. We've got the European Commission. This is the most up-to-date one. We've got more from the Department of Health. We've got the Royal College of General Practitioners telling them what to be doing. We've got more. We've got European Antibiotics Awareness Day. Well, who knew? Okay, but in November, there is European Antibiotics Awareness Day. You've got more things. You've got more stuff from Public Health. And of course, you've got more stuff from World Health Organization. We've also got other initiatives. And so choosing wisely doesn't just refer to antibiotics. And this is choosing wisely from America. Sorry, this is from Australia. You've got choosing wisely from America and also from Canada. Talking about what antibiotics to use, when you should be using them, what are the things you should be thinking about. And these are all freely available online. And they talk about many of those things I mentioned in that challenges slide a couple of slides ago. But when you see that individual in clinic who has a wound, there are many things that you may already be doing. And you can see some of them here. So you may already be trying, clinically, you look at a wound and you think that's infected or that's not infected. But actually, that's just a subjective way of assessing things. But you may have a more objective way, and you may be using any of these to try to score the wounds. And of course, if you're part of the National Diabetic Foot Audit, you'll be using SINBAD. So, but the problem with all of these is that they are just wound classifications and scoring systems. They don't actually guide what you should be doing. And that's one of the problems. And you may be aware, hopefully you've all seen this, but this is the up-to-date guidance from the International Working Group for the Diabetic Foot, led by Ben Lipsky, looking at infections. And it's based on their original 2012 IDSA guidance, which I'm sure many of you are familiar with. And again, from where you're sitting, you may not be able to see it because it's in tiny writing. But as you know, this document is free to download and you can see it online. But again, it talks to you about whether you think it's clinically infected, whether it's mild or moderate or severe, and what aspects, what characteristics of that wound make it into those categories, and what potentially you could do or should do to try and ensure that they do heal up. And of course, going back to that original 2012 document, you say, well, don't treat the clinically uninfected wound. If it's not infected, don't, just because it's a bit red, it doesn't mean to say it's infected. It could just be that's the hyperemia of trying to get the blood down to that wound to try and get it to heal. It doesn't have to, just because it's red doesn't mean to necessarily say it's infected. You only use antibiotics in addition to standard of care, good standard of care. And that's what the podiatrists and the audits are all about. My team will know that I don't get out a scalpel. I don't do all of the other stuff that I leave them. They're the experts. I leave them to do. For mild to moderate infections, you want to use an agent that covers aerobic gram-positive cocci. Staphylococcus aureus, of course, being by far and away the most common organism that's grown in most series that have reported that kind of thing in the world. And of course, for moderate infections, you want to use something maybe broad spectrum whilst you're waiting for specific microbiological results and sensitivities. If you've got MRSA, you need to think about that. And of course, depending on what your local microbiology teams want you to use for MRSA, then that's what you'll need to be used. Talking about the route of administration, IV or IM, and I may talk about intramuscular antibiotics in a little while. And of course, you need to try and treat till it resolves, not until the wound heals. So it's a clinical diagnosis of wound healing. This is what the IDSA suggests in terms of what agents you should use depending on the severity of the wounds. And in the bold, what I've done there is those that there are trial data for in the diabetic foot. And in the italics, I've put in what the Food and Drug Administration in the United States have approved for the use of diabetic foot infections. Now, the problem with those are that actually most of them haven't been used in trials, and those that have been used in trials tend to be more expensive. But if you go to the BNF and you say, well, actually, what is it that's available in the UK? You can see that a number of the original agents have faded because they're not available in the UK. If you then look and say, well, actually, what's cheap? Because actually, let's be honest, we all work in the NHS, or most of us work in the NHS, and we have to deal with what is cheap. Well, we're left with a limited number of agents that we know work, but you have to choose them carefully. So, but what are the limitations to the guidelines that are available? And you can see, as I've mentioned already, that there are very, very few randomized controlled trials, and I will talk about a few as I go along, to help inform us about which antibiotics should be used and when. Most of them are expensive, as I said, and almost nothing about admissions avoidance. And we all do everything in our power to try and stop people coming into hospital because we know that actually it's expensive. It disrupts people's lives. Beds are used up, and that's one of the major failings, as we know in the IDSA, is they just say, well, mild, moderate, severe. If you've got moderate or severe, think about admission, which is possibly a bit too black and white, and maybe should have some nuances about when we could use alternatives to try to avoid admission. And this is what the IDSA say in terms of their classification. But actually, if you've got somebody who's got moderate clinical infection, but actually is systemically reasonably well, they may then consider this. So moderate infection, but borderline for admission. And that's what we in Norwich did a few years ago. We chose to adapt, I was going to say ignore, but we adapted the IDSA guideline for our own use, and we actually started using intramuscular antibiotics as a way of avoiding admission. I'm not going to present that data here. We have presented it before at this meeting. And what we showed is that half of those individuals who previously would have been admitted, we avoided admissions because we used the intramuscular antibiotics. And for those people who were eventually admitted, even because the intramusculars hadn't worked, they spent far fewer time in hospital, which was actually still very much cost saving. So there are things that we could do, and maybe you could do in your own service to try and improve outcomes. I know that many places now have a much greater provision of outpatient services. So you can get a peripheral central line in, a PIC line in, and you could have the district nurses in, or if you've got a hospital at home or similar service, that they can go in and do that for the people who stay in their own home. So this is what we developed in Norwich. We've also got a little bit of flucloxacillin that we now use much more frequently than we did before. But that's the basis of our antibiotic protocol. So they're relatively cheap. We limit all the antibiotics that people can use, and we've got a familiar formulary which is county-wide. So again, something for you, hopefully, if you've already got but if you don't, then please email me, contact me. I'll give you my contact details on my last slide. And then you can, we can send this to you without a problem. The good news is that actually our modification has been at least considered by the great and the good. So on the left is the original 2012 guidance. On the right is the 2020 guidance led by Larry Lavery and colleagues. And so there is a little bit towards admissions avoidance, which is very gratifying. But I talked earlier on about the different kinds of trials that are available, but this is not really a trial. This was a trial, I apologize. This was a trial looking at the effect of oral carmoxyclav. This was published a couple of years ago now. And this group from Switzerland have published a lot, and I will show quite a lot of their data in the next few slides so you get an understanding of this. Is one of the biggest groups looking specifically at what antimicrobials should be used or could be used in the management of the diabetic foot infections. So these guys said, look, Coamoxiclav, oral Coamoxiclav, is a very reasonable option when treating people with foot ulcers and osteomyelitis. NICE, talking about osteomyelitis, NICE says, well, you should always think about osteomyelitis if you've got a positive probe to bone test, if you can see bone, if you think about there's a little bit of erosion on your x-rays. But if you think about it, before you've got an x-ray, you always do an x-ray, or if necessary, do an MRI scan. And certainly we do a lot of x-rays in our clinic, and we have a PGD where the podiatrists can order x-rays. And of course, if they need an MRI scan, then it's usually me who orders that MRI scan. And this again was looked at at the last International Working Group meeting of the diabetic foot, and Eric Seneville and Ben Lipsky were the authors on that paper, which say much the same as NICE, of course. There's been more recent data looking at very old drugs. So rifampicin has been around for 40, 50 years, of course, most commonly used to treat tuberculosis. But these data, which published again a couple of years ago, showed that rifampicin for the treatment of osteomyelitis was actually a very reasonable option because it did actually work. Although it's very difficult giving rifampicin alone because you need to use a bactericidal and a bacteriostatic agent together. So I'd usually use rifampicin with another agent if necessary. But these authors felt it was a very useful agent. However, at around about the same time as both the Coamoxiclav paper and the rifampicin paper, this paper came out, this meta-analysis came out, showing that actually there was no data to suggest that any one particular agent was better than any other particular agent in the management of diabetic foot infections. So we were like, oh, well, that doesn't help us. What do we do now? It's in a bit of a difficult position. So I would say this is when you need to talk to your microbiologist to understand what is the local prevalence of the gram-positive cocci, what are their sensitivities, what are your MRSA rates, what works best. So this is where the microbiology team really come into their own. And certainly we're very lucky in Norwich because we have a microbiologist who I can just pick up the phone to, who I see on our inpatient ward rounds virtually every week, or until recently, until COVID struck and when she was then called on to other duties, understandably. But these are the authors again from Switzerland. This is some more of their data saying, well, how long should you treat them for? And what you can see here, 3 groups of people, those people who had just got infection, those people who had soft tissue infection, osteomyelitis, or post-surgical. And actually, there was no consensus. There was no clear difference between the length of antibiotic treatment for any of those 3 different surgical or medical circumstances. So again, what do you give? How long do you give? No idea, it's your choice. Okay. We've then got the same group. How long do you give it? 3 weeks versus 6 weeks. And again, this was originally published earlier on this year in Clinical Infectious Diseases. And again, there is no consensus. They are much the same. These authors said that actually 3 weeks to 6 weeks were, had the same outcome. So actually, maybe we are treating people for too long. No idea. Of course, I can't get through a talk without talking about COVID. And these authors published in Diabetes Research Clinical Practice, looking at a single centre, looking at what happened to those people with diabetic foot wounds. And as you can see here, the amount of resistant organisms went up, presumably because people were being given empirical antibiotics, or they had a store or their primary care team were giving them antibiotics without getting the appropriate samples from which to dictate which agents should be used. So again, it's all about stewardship when you're talking about antimicrobial prescribing. When we have people who are not well, part and parcel of being infected is you can measure this thing called C-reactive protein. Is that a useful guide? No, these authors said not particularly. Of course, there are other markers of infection, procalcitonin and so on. Again, the jury is out as to whether they're useful as a guide to determining not whether they're infected. I think that's probably the wrong time to use them because the diagnosis of infection is obviously clinical, but as a time to know when to withdraw the antibiotics. Can you use CRP? Can you use procalcitonin? And I think those tools are too blunt at the moment because there are so many other things that can affect the CRP and the procalcitonin that actually we don't know just yet. So as these authors say, you can't use CRP just at the moment. This, of course, was one of the largest studies ever done looking at comparing oral versus intravenous antibiotics in joint and bone infections. Now, this was published a couple of years ago, and as you can see, Ben Lipsky is one of the authors. And the day this came out, I pinged off a quick email to Ben and said, "Oh, fantastic, well done, amazing, amazing, amazing. Can we, how many of this cohort had diabetes, and was it the same?" Because it showed that actually intravenous or oral worked equally as good. And Ben very kindly emailed me straight back and said the number of people with diabetes was so small that we couldn't actually translate these data into the diabetes population. So we were left none the wiser, which was, of course, very disappointing, because it's unlikely that a study of this size is going to be done specifically for people with foot infections. Although you never know, if anybody's out there who wants to throw lots of money at a group of us who wanted to do this big clinical trial, then yes, we'd like to take your money, please. There are, however, so we've got, let's go backwards. There's a lot of unanswered questions. Okay, what's the best agent? How long do we use them for? What's the best way of administering them? Oral, intramuscularly, intravenously? The questions are still there. So as I'll keep repeating, as I kept repeating, your microbiologists are your best friend, you and your microbiological pharmacists, of course. So certainly what we do in Norwich, and we've done it a few times now over the years, is we sit down with the pharmacy team and the microbiologists and ourselves and say, right, what are the characteristics of the wounds that we see? What are the organisms that we grow using the appropriate samples? What are our C. diff rates? And thankfully at the moment they're exceptionally low, which is very, very reassuring, using our coamoxiclav or flucloxacillin or even ceftriaxone and tazocin, as we do if they come in as inpatients, or teicoplanin if they're penallergic. We've had a very, very low rate of C. diff so far over the last decade or more. So you need to be talking to them. What is it that they're comfortable allowing you to prescribe, and so on. But these are the things that are on the horizon, and I'm not going to talk too much about these, but I would encourage you to just flick through the literature as it comes through the door. All of the diabetic foot journals and the diabetes journals and the infection journals, if you're interested, because these are the things that have been mentioned maybe in the last couple of years as coming through. I'm not going to go through many of them, but desferrioxamine as an iron chelating agent to deprive bugs of iron, GTN as a way of expanding and vasodilating, various biologics, usually they're associated with an increased risk of infection because they affect the monoclonal antibodies for many of them, but actually there are others that are potentially beneficial. The neuropeptides for the same reason. Dried amniotic membranes as a way of applying to the wound. So again, they can be very useful. And there are things going on looking at biofilm biology, trying to counteract the harmful effects of that. Martha Clokey, from Leicester, looking at phages, her life's work, and of course used very extensively in Cuba, in Eastern Europe, in Russia, as a way of the virus particles attacking the bugs and leaving healthy tissue well alone. Used very successfully, and we don't use them here mainly because much of the literature surrounding this has never been in the English language, I suspect. And of course, the topical dressings, we've had Ergo, we've had Leucopatch and so on over the last few years. Is there good evidence? No, not really for any of this. And as you know, the International Working Group has a wound healing group, which I'm very thankful to be part of, which this time around Fran Game is leading. And the evidence is looked at very, very, very carefully. It's graded. And because the quality of the evidence for the vast majority is very poor, most of the recommendations are consider and the strength of evidence is usually fairly modest or poor, apart from some of the very newer trials in wound healing, such as Leucopatch and ErgoStart. However, the amount of evidence is very small. So again, it's modest or moderate level of evidence. So I'm coming towards the end now, really. So the title of this talk was, a pragmatic approach to the management of infections in the diabetic foot. And so these are some of just my thoughts about the pragmatic, the way to approach the wounds and the infections is that the microbiology of the foot is changing. Okay? It's always changing, and you need to keep on top of what are the trends coming through your clinic and from your catchment population. It's an enormous amount of work to do. There's so little good quality evidence to show what works and what doesn't work. And even the work that has been done is so heterogeneous in nature that you can't make overarching statement saying antibiotic X is better than antibiotic Y in this particular circumstance, because it depends on your local circumstance, as I've continuously said. Talk to your microbiologists. And again, I think that intramuscular antibiotics, or the use of hospital at home or outpatient antibiotic services as a way of providing that intravenous or intramuscular service to try and prevent hospital admission, is something that we can all think about, because at the end of the day, it's our money that we're paying towards the NHS, and if we can save it, that is probably going to be a good thing. So this brings me to my last slide, and it really just leaves, it just left for me to say I'd like to thank the organisers so much for inviting me to give the talk. As you can see on this slide, these are my contact details. If there's anything that you want to ask me about, then feel free to tweet me, to email me, and I'm usually pretty good when I answer if you ask a question for me. So with that, I hope we can all meet again next year in person, or whenever the conference is next held. And thanks very much, and goodbye.